we're going to be doing today is hearing a presentation from Donna Kinzer with DK Healthcare Consulting. And just as a reminder, we began this process, I don't know when, several months ago. Thank you. And we are on air, just as, so we are now being live streamed and recorded. We began this process several months ago with knowing that we wanted to look at the costs associated with the healthcare system and understand them a wee bit better. And thanks to Senator Kitchell, said, why don't we talk with Milbank? And they graciously gave us some time to kind of frame and give us a context for this discussion. And through that, we decided, and as part of that conversation, we heard from Donna Kinzer, and through that, decided that we would like to have kind of an analysis of what is happening today, what the current system is looking like, so that we could be smarter as we go forward. So I wanted to say one thank you to this group of folks who have been engaged in this summer conversation, and to Milbank for helping us start off with this, and then also to Donna Kinzer, who we contracted with for the report that we're going to hear, but she's also given us quite a bit of her time in addition to that. My thought was that we would hear the presentation from Donna, from Ms. Kinzer, and I would like to suggest kind of hear it in whole, maybe stop for clarifying questions, but subsequently go back and have a deeper dive into the elements of it that we need to understand and figure out if and how to engage in legislative action as appropriate. So that's kind of my plan for the morning. We've given ourselves a lot of time, but we don't have to take all of the time either. So with that, can we turn it over to you, Donna, Ms. Kinzer?
Yes, and you can call me Donna, so thank you. Chair Hooper and committee members, thank you very much for the opportunity to talk with you today and to work with you. I'm honored to serve you. And I also want to thank Milbank as well. I was a state official, as you know, in my past, running the Maryland Health Services Cost Review Commission, and Milbank is a very helpful organization with state officials. So I also want to thank Milbank. And as you will hear as we go through the report, I also talked with about 45 folks in the state about information in the report and about policy. And I want to thank all of the folks who made time in their schedule to talk with me and work with me with the data reports. So I did want to make sure to thank those folks, including and especially those who reached out and asked to speak with me and share their thinking about the state of the regulatory system. The plan, unless we change it right now, is to walk through the report with you referencing your handout. I will bring a few slides up on the screen just where we want to look at them more closely. But if it's all right with Senator Lyons and Representative Pugh, will follow along through the report. And I know that Representative Pugh might not be on a video screen yet, so she may not have access to the report. So I'll be careful to try to make sure that I'm describing things as I'm walking through and not just referencing something that's on the page. So is that all right with you, Senator Lyons, or and everyone else in the room?
Thank you for
Yes,
that.
thank you.
Yeah, we had suggested, we're not very good at screen sharing, and so we had suggested that we not try to do screen sharing and instead refer to the hard copies, which is a flaw for those who aren't with us, but they have also received the copy of this and could look at it on their devices.
So on page 2 of the handout, there's a table of contents of the report, and that will lay out what we are going to talk about, which will start with me discussing the approach to the evaluation, then a review of cost information that's available for the legislature and gaps in cost information. Then we'll talk about the drug costs, which aren't currently under the all-payer model. Then we'll discuss the themes that came out of the interviews with your stakeholders about the regulatory structure. First, about the general regulatory structure in the ACO model, and then secondly, some more specific themes about the implementation of the ACO and the all-payer model and where that stands. And then we will complete the discussion by looking back at all of the recommendations that are in the document, and hopefully at that point discussing the recommendations in more detail and in terms of what the committee might want to consider. There are also a few appendices that we may refer to during the process. Moving on to page 3 of your document, I just wanted to start out by talking about the objectives of the engagement and what we set out to do. And referring back to the August meeting where I attended with you, the committee is considering the evolution of the regulatory system with a focus on enhancing opportunities to manage cost and improve the value of the delivery system. And so that's an important context of what is driving the work activity. And what I set out to do is to evaluate what cost information is available to the legislature and to the committee as you consider changes in the system. So is there enough cost information to tell you what are the best opportunities to reduce cost, where are costs growing, and what costs are being regulated, and what are the implications for the regulatory system. And then as a second part of the process, I set out to evaluate qualitative information, and that is perceptions of the stakeholders and policy leaders regarding the system performance and future cost containment strategies that might strengthen the regulatory system. And I do just want to point out something that, of course, you are very aware of, is that the healthcare system is under extreme stress and continues to be under extreme stress with COVID-19. And that will affect the performance, but also the speed at which you might consider changes to the regulatory system. moving on to the next page in the report. I want to discuss the approach that was used in the assessment, going back to the objectives that we discussed. The first part of the approach was to focus on the evaluation of the data that's available. I think I probably reviewed more than 30 reports, and I looked at data manuals, I looked at data tools, and I interviewed the data collection personnel in the state staff to evaluate the data that was available for the legislature and the committee. And then the second part of the work focused on discussing the performance of the regulatory system of the all-payer model and the ACO with policy leaders and with advocates, with some consumer advocates, purchasers, policy leaders, as well as individuals who are involved in the delivery system and the state regulatory system. And then finally, the report pulls this information back together and summarizes it, interprets it, and makes some recommendations. So that is the process that was undertaken. Moving on to the next page, we're just reviewing some of the effects of COVID-19 pandemic in terms of, as I mentioned in the opening section, there are serious challenges in the healthcare system as a result of COVID-19, including distortions in data and utilization for 20 and 21, as well as serious workforce problems and mental health and substance use crises in Vermont, as well as the rest of the country. So I just want to point that out as we think about the pace of change and also the performance of the system. So moving on to page 6, and I'm going to start through discussion of the data analysis and data availability first. On page 7, there are two types of data or two uses of data that I'll be talking about today. And I'm going to really focus in this first section on data that is used for health policy. And that would be information about cost levels, cost growth, cost comparisons, opportunities for cost reduction. And we're trying to look at those on a per capita basis. So we're seeing what information is available about cost on a per capita basis by payer. Is there a sufficient level of detail to drive policy? And equally important, and I will focus on this a little bit more later, is information that's needed to support delivery system transformation, because that is where it happens on the ground, and that information also has to be available. But first, we're going to start with what information is available for you as policymakers. And moving to page 8 of the presentation, there are two main data sources that of cost information that are very high quality and useful for the legislature. While there are other data sources as well, these are the two that I'm focusing on as information that can help drive your policy process effectively. So the two sources are the Vermont Healthcare Expenditure Analysis, which actually came about as a result of the legislature. And the second one is the Vermont Healthcare Uniform Reporting and Evaluation System, VCURS, or your all-payer claims database. The first, the Vermont Healthcare Expenditure Analysis is a comprehensive view of all expenditures. And it is by, it does have information by payer. It has total cost. It has spending by cost category. It has per resident spending. One thing that's really important is that it is able to capture spending that happens out of state. So you have very heavy border crossing into New Hampshire for your residents. So it's important to be able to capture that cost. And this expenditure analysis does pick up both in-state and out-of-state expenditures for your residents. Now, the data in this particular report is at a summary level. It's not at a patient level. So it doesn't have the granularity that we'll talk about in a minute in the VCURS data. But the benefit of this analysis is that it includes costs that aren't coming through on patient bills. For example, some of your mental health services come through grant programs. The long-term services and supports, those are, many of those are not coming through on patient bills. So and we also have the uninsured. So this database really is comprehensive and is focused on including all costs, all expenditures. The VCURS is moving over to the VCURS. This is the all payer claims database. It is also has information for the residents at a very much more granular level, at a person level. So this information is coming from the claims or the patient bills, if you will, that have been paid by the payers. What is not there, and so all of those costs that are not on a patient bill are not in the VCURS. So it doesn't give you a complete picture of all of the expenditures, but it's very useful for more detailed analysis. And I'm going to talk a little bit more about these two data sources. And on page 9, again, the annual expenditure analysis. As we said, it's a comprehensive source. It is a high quality resource for macro policy analysis for the legislature, for the HROC. This is a very good macro level resource to understand costs and cost changes. And the Green Mountain Care Board has a well-documented process for obtaining the information and for telling the user where estimates are included and how those estimates are derived. And they also have a tool to display the information that comes from this resource. Moving to the VCures, the VCures is the source for your all-payer model performance. So it's even though it's incomplete in terms of having all of the cost, the folks want to be able to drill down so they can check the what's behind the performance. It's used for more granular analysis. So if you wanted to know something more particular, like how much did maternity costs grow? What were the maternity costs? What was the surgery cost? Anything that's at a more detailed level would have to be analyzed from this data source. The shortcomings of the data source is that it doesn't include all of the self-insured population because they under the ERISA rules, they were not required to submit their data to the APCD. However, you've been very successful in getting voluntary submission, and it's up to about 80% of coverage of the private population. As we said before, the principal source of this data is the bills. The data is very complex. It's not easily accessible, and because it is at a patient level data, there is a very careful access to the data with data use agreements and protection of the confidentiality of the data for the patients. The Green Mountain Care Board has had a consulting group prepare a report on how to make the data more accessible and more usable, and they are working on trying to make that data set more usable than it is today, and with its complexity of trying to do summaries and do other things with the data to make it more usable. Another thing that is happening, and this is a very important development, and will likely be coming back to the legislature at some point in the future. One of the most important opportunities, which of course you know, in terms of cost containment, is really focusing on the health of the population and improving the health of the population. And the state, the Green Mountain Care Board and other parties in the state are working to try to link clinical and cost data together, and doing that in a very secure way, and that may require some changes in the way data is collected, which may end up coming back to the legislature. But that's a very important activity that is taking place, and an evaluation that is taking place now. So those two data sources create very strong resources for the legislature to be able to evaluate cost and cost growth in the state at a summary level and at a granular level. But there are some gaps. And moving on to page 11, the area where there are gaps is the ability to compare your spending levels to other states and to better performers. So if we're going to try to find opportunities to reduce cost, it's good to be able to compare to better performers. It's good to understand the expenditure level. And as we look to what information is available, the comparisons to states or to areas outside of Vermont are uncertain, and they lack sufficient detail to really help point in a direction of cost containment. For example, if we look at the Medicare data shows lower spending for Vermont compared to the national average. But the national health expenditure accounts show different data, show a different result when we look at the total spending per capita for all Vermont residents. Unfortunately, the national health expenditure accounts aren't trusted by folks in the state because they have a lot of allocations. Because you have so much border crossing, there is a lack of trust of that information. And it's also not at a sufficiently detailed level to really point you in a direction of where you might have cost containment opportunities. So that brings me to the first recommendation, and that is that the Green Mountain Care Board should consider engaging a third party to prepare a per capita analysis, a comparative benchmarking analysis. Ideally, it should be at a granular level, so it could be more useful in pointing to opportunities. For example, at the HSA level and including cost categories, so you can see where you might be higher or lower in utilization or in cost per unit. And that should be looking at national levels, peer levels, and better performers, because you want to look at better performers to make sure that you're finding the opportunities. Several states are also looking at avoidable utilization and waste with their all-payer claims database. And if you were going to do this benchmarking analysis, it may be very useful to tackle that at the same time, so that it helps to point in a direction of opportunities to reduce cost and reduce waste in the system. And with that benchmarking analysis, you would be able to put a stake in the ground and definitively say what the performance level of the state is in comparison to others. Moving on to the next page, the second recommendation is, as I mentioned earlier, I probably reviewed 30 reports. And that took a number of days of review and scouring reports. That is a lot to ask of the legislature. There are many high quality reports. So the recommendation is that the Green Mountain Care Board should summarize the reports and also provide analysis and implications from those reports for the legislature, so that you would have all of the key reports summarized in one place. That is the second recommendation. Moving on to the next page, 13. Now we're going to turn and talk about the regulatory system and part of what it covers and what it doesn't cover. And the the next area that we're going to talk about is drug cost. And I am going to turn to page 14, and I'm actually going to put a slide up on the screen here. Do you see a slide that has some expenditures on it? Okay.
Yes.
Yes.
So this is a information that was derived from your healthcare expenditure analysis report that I mentioned earlier. And this gives you a picture of the expenditures in the health system for 2019. And you can see at the top, there's 6.5 billion in total expenditures.
Ms. Kinzer, we lost you a wee bit on the audio. I don't know if you pulled back from your mic or.
Can you hear me now?
Yeah. Yes.
Okay, sorry about that. Please let me know if I have any other audio issues here. So this is the a view of expenditures from the healthcare expenditure analysis report with 6.5.
So we are, sorry to interrupt again, Ms. Kinzer, we are having trouble.
Let me just check.
Pull it down, and we've got the,
Yeah.
we've got the.
Are you still having trouble?
Yeah, and we're wondering if it began when you put up the screen share. And
Well, let me pull it back down.
Yeah.
And if that doesn't help, then we'll move to a different device. Sometimes when we have snowstorms, we have problems with internet in the area. But I do have an alternative device. So let me stop. Is the voice better now?
yes, yeah.
Okay, well, let's not screen share for the moment and talk from the page instead. But we'll walk through it. If you're looking at the page, we see that there's $6.5 billion in total expenditures, and the right-hand side in green shows the amount that's under the total cost of care model, the APM, at just over $3 billion. Underneath that, we see that there was about 895 million under the ACO, and the non-ACO portion of the APM has about 2.1 billion. So, and we're gonna end up talking about that again in a few minutes, because with that amount of money that is not under the ACO, Senator Lyons, did you have a question, or you're not hearing me? Not.
A quick question. I think that you said 6.5 billion, and the slide shows the M for million. I want to make sure that it's accurate, that the slide matches the total amount.
Yes, that's based on the way because it has a comma there and the way the zeros are.
Okay, I got it.
So
Thank you. It's an early morning brain cramp. Thank you.
No, it's always difficult when you have some items that don't round nicely to decide whether to put a B there or an M there. But so we have a lot of of expenditures that aren't under the ACO. And you'll hear later as we talk about that results in a lot of fee-for-service incentives still being in play in your system. Now, I will tell you, I just looked at the 2022 ACO review, and that number is moving up. So it's now the ACO is getting close to 1.4 billion in coverage. Now that 3 billion in the APM total cost of care will go up with inflation, but the ACO percentage is moving up. But it's still more than half of the system is on fee-for-service, and even in the ACO, there's still a lot of payment that is not fixed payment, but a shared savings program that doesn't have a full set of incentives, that it still keeps the system tied to fee-for-service incentives. When we look at the left-hand side of this analysis, you'll see drugs and supplies, which I'm going to talk about more in a second. And those are not under the all-payer model, and they're not under a strong regulatory or cost containment system with the potential exception of Medicaid at the current time. Government health activities, we talked about things that might be under that category, such as the mental health administration, some of the long-term services and supports, so that's what you would find under that government health activities. But the areas that we're going to spend more time talking about are really the drugs, and also getting back to this amount of fee-for-service cost that's still sitting out there in the all-payer model. And that gets us to slide 15. But did anybody have questions about that cost page before we moved on? So that, that's a very strong information that can come from that expenditure analysis that we talked about earlier. So that gets us up to the next page 15, which when we look at the data that's available, we see that drug costs are among the highest cost growth levels. And as I said, most of them are outside of the all-payer model. And there's not a heavy focus in the regulatory system on drug cost containment. So the recommendation that comes out of that is to consider additional cost containment strategies for drugs. And there are the NASHP, which is the National Academy for State Health Policy, has been working on cost containment strategies for states, and they might be a resource to discuss opportunities with. But also, I'm a strong believer that your doctors and ACO providers can also contribute to cost containment. Now, that may not, they may not be able to affect the price of drugs, but they can affect the selection of drugs that are being prescribed for patients. And so I want to give you just a couple of examples of that so that you can see how that might come into play. And so I'll give you some personal examples. My husband has high blood pressure, and it's congenital, and his doctor prescribed a pill and for his blood pressure recently, And he said, this is the greatest thing. It's a new pill. You only have to take one pill a day instead of multiple pills. He found out that that pill cost him out of pocket, not including the amount that the employer paid, $300 a month. So that's a lot. And he works in the healthcare field, and he went to the pharmacist and said, look, this is not reasonable. What's the alternative? And the pharmacist came up with alternatives. And so the outcome is that he takes 3 pills instead of 1. He said, I can swallow 3 pills instead of 1. And the cost to him is 0. And all of the pills are generics. And he's able to use that instead of that very high cost brand with high cost out of pockets. So the doctors and the providers in the state can play a very critical role in selecting medications that are more cost effective. And I could sit here and give you multiple other examples. And I can tell you that ACOs and doctors in other parts of the country are working on some of these strategies to try to not only deal with the price of the drugs, but which drugs do we select and prescribe. So that is an important recommendation, because there's such a large, as you saw that orange section on the document, there's such a large amount of costs that are not under the model and that are growing rapidly. So
Single formulary for the state.
Right, yeah.
pardon me?
Well, what I was saying, Donna, was that I'm back to the concept of a single formulary for the state. If it's cost effective, it's efficacious, it's gone through this review process, and then docs only have to refer to one payment, one formulary, as opposed to, well, you're enrolled here, you get this, and so forth. The only question, of course, is Medicaid views that they've negotiated the best and have a number of constraints. So, but anyway, it just seems to, what you're saying seems to tie into, we're only 640,000 people. I just want to throw it back out there.
Yeah, so I mean, ultimately, I think those are good strategies to discuss with NASHB and to consider is, can you at least consolidate the formulary in any way? So, for example, some of the states did consolidate formularies for all of the state and local government employees, and along with Medicaid, so that they were trying to increase the buying power and do more standardization. But I think there's, multiple strategies that NASHB might have, but also just the opportunity with your system being as vertically integrated as it is, meaning that the doctors are part of the hospital system and owned by the health system. The information flow should be better, and it should be easier to work with doctors in your state on drug strategies than some other areas where the physician ownership is more fragmented.
Can I make a quick comment?
Yes.
Thank you. So when I hear this, I am very concerned about the cost of drugs, and I think we need to continue to work on that. But then going back again to slide 11, where you're talking about looking at comparative spending levels, which would be a part of this, I would think. One of the concerns that I think we all need to keep in mind, as simply a comment, is that we need to look at the quality outcomes. And if we're going to use our ACO appropriately, to look at best clinical outcomes for folks and to weigh that against the various costs that we're trying to control and regulate. So it's a broader discussion. certainly it isn't all about, I've had a similar experience to your husband's this summer where my husband went to pick up a prescription drug and the cost was $1,300. And I thought, whoa, wait a minute. I'm going to have to go to a lot of meetings to earn that. So having a process for negotiation and looking at what are the best outcomes related to the type of drug that's being utilized, I think is critically important.
And Senator Lyons, it's very important to maintain access to important drugs that can't be substituted because they really are needed for that patient. So it's important to eliminate, when it's not needed, to eliminate that excessive cost so that we can afford the drugs that really are needed, that are unique and that are expensive. So I think that's during the interview process, and one of your stakeholders told me the story of her relative who did not take the drug that was prescribed because they couldn't afford it. It was going to compete with their food money, and they ended up in the hospital. So, that's if we don't get the drugs there and the cost-effective drugs and address the affordability, we do end up with people in the hospital because their conditions spin out of control, and that is particularly happening with Medicare folks who, if they had to pay that kind of out of pocket, it would take all their food money. So, it's an important area to make some progress. And now we're going to turn to the section, page 16, where we start into some of the interview findings and what some preliminary information from stakeholders. Of course, this isn't a great big large committee with input from everyone in the state, and it is an interview process with a set of stakeholders. And some of these recommendations might ultimately need to be exposed to larger stakeholder groups. But the first interview theme is really about the ACO and the all-payer model strategy. And generally, the stakeholders continue to support this strategy, which is really having the providers take accountability for the cost and outcomes of the population. And that is something that builds on what Vermont has really invested in historically, which is the blueprint and the primary care relationships, the prevention and the chronic care management that you've so carefully built and implemented. The ACO strategy builds on that strong vertical integration that we just talked about, which is the hospitals owning 80% of the physician practices in the state, which has potentially some downsides, but it also has the upside of creating opportunities for better care coordination and better integration of activities. And also the ACO is viewed to create the opportunity to work across the health system as patients move from one provider group to another provider group to better coordinate the care. That being said, there are some alternative views to the support, and that is some folks think that the ACO hasn't added much on top of what the blueprint was already doing. So I think that some of the concerns with the ACO partly stem from implementation issues, which we're going to address in the next section. But that there are two sets of views. One, it's a good approach conceptually, and the other, it hasn't added much. I do want to say that the ACO strategy is in line with what CMS is doing, and that they're attempting to roll out nationally. So I've included an attachment on page 31 that shows you the CMS strategy. And at the very left-hand side, the #1 cornerstone of the CMS strategy is accountability and the accountable care. So this is very much front and center to where CMS is going. And that's always important since they're an important buyer of purchaser of services. And they've engaged a lot of thought leaders nationally into their strategy. So I want to move from there, if there aren't questions, into the second interview theme. And this relates to alignment of the regulatory system. So the regulatory system started long before the ACO and the all-payer model. And the concern is that the system is kind of stacked. So it's this one stacked on top of this one, stacked on top of this one, and they're not always aligned. If we're going to go down the road of trying to continue an accountable care strategy and getting providers into value-based payment arrangements and off of pure fee-for-service arrangements, there's some opportunities to align things better. And I've described that as nesting. So trying to nest the hospital budget review process so that it will be done in a more similar manner to the ACO review, looking at per capita cost and looking at the total cost and getting away from individual budget reviews and rate reviews and looking more at the per capita cost. The second piece relates to your certificate of need system, which is very detailed. And if your providers start taking more responsibility for the total cost of care and they get off of fee for service, then for those providers that are taking the responsibility, there may be less need to do detailed CON reviews on every replacement item. For example, if the provider's responsible for the MRI cost, do you need to review that provider's MRI replacement? So there's some opportunities to streamline and make these processes align better as we get more cost off of fee-for-service. So the recommendation here is to, as more revenue or cost is moved off of fee-for-service, to look for opportunities to streamline and align these regulatory systems. At the same time, I just want to be clear that I'm not recommending that you eliminate regulatory systems because the state has too many areas where there's really no competition. So we need some regulatory systems to step in and where there's not adequate competition. And I'm going to get into much more detail on the hospital payment model on the next slide 19, which is the alignment of the hospital review and payment model with the all payer model and the ACO strategy. And if you reflect back to the conversation that we had on, I believe it was slide 13, where we were looking at how much money is under the all payer model, and that an awful lot of it is still on fee for service. So that is potentially conflicting with the goal of having the providers focusing on cost containment. And I want to ask you to turn to page 33 in your handout for a minute. And because this ties into the cost containment strategy issues. I'm not going to spend a lot of time on this slide, but if you look at the slide on the right-hand side, I've circled a box that has a lot of green in it. And in the middle is a box that has a lot of red in it. And basically what this slide is telling you is that the inpatient services in the state are being paid out at less than cost. The outpatient services in the green are being paid out, a lot of them at greater than cost, to create a net that is, at a break even or a little better in many cases. In some cases, it's a loss. But the issue that I really want you to focus on is the green. And there are a lot of opportunities for that. So basically, your hospital system is dependent on outpatient services to make their bottom lines work under the fee for service construct. And that means that the choices that they make to keep their bottom line in place aren't always going to be in line with good cost containment strategies. So my favorite example is sleep centers. Most sleep studies can be, and I'm just using this as an example, but most sleep studies can be performed in doctor's offices or home settings. But many hospitals have sleep centers because they create a margin that helps to subsidize that inpatient underpayment. And so this is where we start to get to the opportunity of changing the payment construct to align with the ACO process of how can we get the hospitals off of a fee-for-service payment so they can make better choices in terms of what services they provide in the hospital versus what services they put in the doctor's office without threatening their viability. So I'm going back to page 19, and so that was just the point to make from there is the dependence on outpatient services. So of interviewees raised this issue and said we should consider looking at opportunities to change the budget review process and potentially move to a fixed payment system for hospitals. And that could align better with the ACO strategy. And the beauty of what you might be able to do in Vermont that others might not be able to do in other parts of the country, because you have so many doctors under the system, you may be able to put the hospitals and the employed physicians under a fixed payment budget or fixed payment arrangement, and that could get a very large sector of providers off of fee-for-service and lined up with where you're trying to go with the ACO model. So the recommendation is that you consider this option, to work with the Green Mountain Care Board to change the payment approach for hospitals in their employed positions to a fixed payment, and that would allow them to make better decisions about where to provide services in the most cost-effective setting without affecting sustainability. So that's the idea here with this recommendation. It's not an easy process to accomplish, and it would need to have some thoughtful consideration. Do we have questions before we move on to the next section? All right, so we're on to the, yes.
I have a question, or just one of the things that we will be looking at is within this environment, what is doable now and what is going to be take longer. And it seems like this recommendation is one that is the implications are fairly in terms of the implementation and the work necessary would be a longer term recommendation. Just wanted to ask. That's one of the things we're going to be looking at is what is doable now. Some of them are probably doable now, and what would recommend the recommendation would take more time than we have in an 18-week legislative session starting in January.
Right. Yeah, I would just join Jane. As we've gone through this, I've several times been writing down timing because I think we have to be really aware of what it is that is achievable.
Yeah. Sort of stack it,
Yeah.
in terms of what will help us first. Obviously, some are, the first recommendation around putting money in the budget for the Green Mountain Care Board to retain someone to get the data might be more something that we can do short term. But I just wanted to think about the recommendations relative to our capacity to really work on them in the environment that we have ahead of us.
So I do think the implementation of a recommendation like this would take longer, but the short-term action would really be stepping forward to say, yes, we would like to consider this and initiating a process to consider it, so that that a broader set of stakeholders could be brought into a conversation, that there could be some preliminary evaluations of a design that could potentially make it workable and implementable. So it's not that particular recommendation. The short-term action would really be more input and evaluation. Senator Lyons, did you have a question?
I do have a question. Thank you. As you're going through, obviously, these are interview themes, and it would be interesting to know which of the stakeholders supported this or made this suggestion. Does it come from the hospitals who see an opportunity for greater financial sustainability? So just curious as to where this derives.
So it actually, and I'm always wary of bringing out something to you that only came from one stakeholder. So I actually heard it from multiple stakeholders. The need to move off of fee-for-service was brought up in the CMS evaluation. You'll soon get a sustainability report from the Green Mountain Care Board, and there's some suggestion of that this may be an option. I talked about it with consumer advocates who are concerned about too much money still being under fee-for-service and not enough attention to affordability. And that the thought was that this should be examined by some of the consumer folks. And the health system folks thought that it should be examined. That doesn't mean they would rally to support when the details are starting to come forth, but it actually came from almost every stakeholder group that there's a concern that there's still a conflicting situation where the hospitals are still tied to the fee-for-service system, yet folks want to move forward with this ACO concept of accountability concept, and it's pulling in opposite directions at times. So it appeared to me from the conversation that multiple stakeholder groups thought that it would be valuable to consider it. Does that answer your question? If it were just
Yes,
one,
no, thank you very much. It's very helpful.
If it were just one, I probably wouldn't put it in the report. So I'm just letting you know that I'm listening to a lot of different voices and trying to be balanced. The next section then starts into the ACO and the all-payer model implementation. And actually this reflects back on what you just asked me, Senator Lyons, relative to some of the consumer and purchaser side of the equation. The question about affordability and how do we measure affordability and assure affordability, because healthcare spending, it's not only a measure of how much the spending is going up, but also what are the other impacts of healthcare spending in terms of crowding out other services or resulting in lower wages for workers. And so the conversation about this was that it needs to be more tied into the affordability to the consumer needs to be tied in more to the goals that are set. And so the suggestion here is that the historic all-payer model targets were set. I think 3.5% is or 3.5 or 3.6% is the target. But now we're at a different point in time. The recommendation is to consider whether Vermont could benefit from having an expenditure growth target in a defined context created with a larger stakeholder process, and recommend and considering all the components, not just the health system, but also the drug cost, et cetera, and so forth. So consider developing a target. And the examples that were used for this were things like Rhode Island's affordability standards target. I think Massachusetts has a target, several other states have a target. So consider developing a target, and that would create a clear set of goals for the system in terms of affordability. The next interview theme, if there aren't any questions on that, the next interview theme relates to the implementation of the ACO and the all-payer model. And to start that conversation, there have been some very substantial accomplishments with Medicare savings generated. The Medicaid has improved the predictability of cost, and that is a very big deal to begin to lock down the annual Medicaid cost. Many of the providers are in the ACO model, and they're improving their ability to transform care and reduce costs. Data structures have been put in place, and there's been good progress on the data structures. But there are concerns with the implementation, and I think this gets back to some of the earlier comments about that folks had raised about whether things are better than the blueprint. And these are not new issues. So your state leaders know what these issues are. They created an 18-step implementation improvement plan, which I've just attached for your reference on page 34 and 35. And I'm just going to focus on two things out of those concerns that were discussed heavily in the interview process. And the first is about the data that's available for care transformation, which I'll get to in a minute. And then the second relates to the governance of the ACO. And so if we move to page 23, the interviewees, some of the interviewees identified continuing concerns with having the data to drive transformation and cost containment. And there's a particular set of information that I would call as a best practice data set. The information needs to get to the provider level. And so the doctors and providers need to be able to know what the gaps in care or gaps in preventive services are. They need to know which patients have chronic conditions to manage. They need to know where there's waste in the system. For example, excess radiology utilization. And all of these things need to come together in a timely, organized process with transformation support. You can't just build it and expect the doctors to go into some database and access some information system. The build it and they will come doesn't work for data use and transformation. Regional Medical Center. Support. So, and I want to just say that the data coming into your ACO, so I'm going to put the little defense hat on for the ACO here. Your ACO has dealt with very raw data from Medicare and Medicaid is raw data, and probably even from the commercial payer, it's coming in raw. If I were going to the best in class commercial payers and Medicare Advantage payers in the country, what they're delivering to their ACOs is data that's already digested, summarized, and ready to go to the physician. So your ACO has had to work on trying to create digested information. That's a hurdle. On the other hand, the expectation with the funding that you've given is that they would get there. So I would say from the interview process, which I have a caveat, this is a small population of interviews, they're not there yet, but it's also identified in the improvement plan from your state leaders that the ACO is not there yet on all of the data that it needs, and on the transformation resources to help people use the data. So those are some gaps in the implementation that I'm focused on in particular. And that leads to recommendation number 7, which is that there needs to continue to be a concerted process to escalate this issue and make some decisions on how to move the data and the transformation resources to the next level. Should some of the transformation resources be deployed in each community? And I heard in the interview process that some communities do have transformation resources and others don't. So there's some unevenness to how things are implemented. Should we expect the ACO to do this, or should we move some of the data model process outside of the ACO, for example, at the Health Information Exchange? So, those are some careful thought processes and approaches that need to be worked through and thought about. So that is the recommendation, is to continue and escalate this data model consideration.
Go ahead, Bill.
I do have a question to understand more. When you talk about should there be transformation resources in each community, can you say more about what you're referring to? Because I don't have a clear understanding of what that means.
Okay.
Particularly as we're talking about data and resources. So help me understand what that suggestion,
Right.
what it,
Okay.
I literally don't know what it means.
Okay, I will do that.
Thank you.
So, going back to the comment that the doctors are not going to go into a computer to pull the data out. So they're cranking through X number of visits and patient care per day. A transformation specialist is a person who's trained to get that data and to take it to the providers who are needing to act on that data and to filter it and tell the providers what they need to do and make sure that they have the specific information in a very digestible format to improve care. So in other words, Dr. X gets a list through the transformation specialist and through here's what you need to do to close these gaps in care and these gaps in your preventive services. These patients haven't had their colonoscopies, and these patients haven't had this, and these patients haven't, their blood pressure is not under control, and these patients' diabetes is not under control. So these are work lists of things that need to be accomplished to improve the care delivery, or bringing the information about radiology use. You're ordering too many MRIs for things that that are considered to be waste by the medical experts nationally, or so really distilling the information and working with the provider. So that transformation resource has to be able to distill and work with the providers directly. Does that answer your question?
Yeah, that helps. It helps. I think I right now, I think the information is attempted to be provided as feedback rather than directives. And so it's a bigger conversation about what role is played and from where.
Well, and I'm not really saying it shouldn't just be feedback, or I'm not really trying to say it should be a directive, but if somebody has to go into a workbench to download something.
No, I understand. Yes, I appreciate that.
That's really the it would be,
Also be a driver.
the providers aren't fluent enough in the data to use it without some support.
Yes,
So it's about data fluency and accessibility and distilling down to the most important things. Does that answer your question?
that's helpful. Thank you.
And Senator Lyons?
Yeah, I think this is an area, this is a strong interest of mine, and the question is regarding the quality metric analysis that is available through ACO data. And so as data is gathered about patient care, then a transformation for whatever care it is, whatever condition it is, can take place, but it requires a lot of work on the part of the folks who are giving the care, and regulators. It's difficult because what we're talking about here, I think, at least in part, is how medicine is practiced to achieve the greatest outcomes with the least cost. So, I mean, it's having sufficient resources for the clinical data analysis is how healthcare is transformed, how we will get there. So it's all a great question, and no one wants to practice medicine in the legislature, but we do
No.
want to ensure that data is available for people when they need it.
Yeah, just was gonna say, if only.
I'm not sure, Jenny.
And I kind of liken it to, well, we're trying
I know that was kind of a facetious sarcasm.
I kind of liken it to what we're trying to do for the doctors and the providers is help them decipher what's the best opportunity and the best areas to focus on. So imagine if you got a list of your lab test results and there wasn't anything on there telling you what was a problem. And so I wouldn't know how to read the thing, so it's really making sure that the data gets to a point where it's actionable and usable and that it's prioritized. So, the high mark on my lab test results of where I'm out of line, that's telling me what I need to prioritize. And so we need to do the same thing for our physicians, is to tell them what they need to prioritize, not to tell them what to do, but what to prioritize and help them with the workflow, because there's a lot of patients. So that's really the bottom line. And that is the last recommendation, and gets us to the back into the summary, which is on page 26 and 27.
One more.
We're confused because you have on page 24 slide or recommendation 5B, one care affiliation.
Oh, actually, so I apologize. I left out an important, sorry about that. Thank you for catching my run by that one. One more recommendation. And this relates to the theme that was raised in a number of the interviews about the One Care affiliation and control. And there's the One Care is a sole member, is the University of, an affiliate of the University of Vermont Medical Center is the sole member of One Care. It's a 501c3 entity. However, One Care is not operated by that affiliate. It's operated by a governing board of 21 members. And out of that 21, the University of Vermont Medical Center affiliates comprise 4 seats. So the board is dominated by members who are not part of the UVMMC system. In that document, the governance documents on the internet, so I put a link to that for you. The OneCare develops the risk and shared savings model for the ACO arrangements and some payment arrangements for providers that are part of the ACO. And they have made changes in some of the risk structures to accommodate the smaller providers, because there was quite a bit of complaint at the beginning that the risk structures were too volatile for the small providers. But the heart of the concern that's expressed is that there's, since it's a single entity and its sole member is an affiliate of the University of Medical Center of Vermont, is that a concentration, and is that an area of concern in terms of control? And folks also pointed out that the University of Vermont Medical Center has started a Medicare Advantage product that's not currently under the ACO. So that was also, that these are some of the concerns that came out relative to the ACO entity. The concerns that would derive from this is there too much concentration? Do consumers have the right grievance processes available to them through this arrangement? And so this leads to the last recommendation, and this really is the last one, to evaluate, because the Green Mountain Care Board also already has authority over certain aspects of the ACO arrangement. Do the regulatory processes in the board structure that's in place provide sufficient protections, or is there a need for any additional changes or enhancements that could take away some of the concerns and give more confidence in in this control structure? So that's the recommendation, is to continue to evaluate whether there are opportunities to enhance the structure or the relationship to the various stakeholders, consumers, providers. So that is the last recommendation. Recognizing that there is an operating board that is different than the University of Vermont Medical Center, that there's already an operating board, but wanting to make sure that those structures are in place to the maximum benefit of the consumers and the independent providers. Are there questions before we move on?
I'm not seeing any, so I think we're ready to turn to the recommendations.
Yes, so page 26 and 27 summarize all of the recommendations that we just went through, and actually 26, 27, and 28 summarize all of the recommendations that we just went through. And I'll just quickly run through them, but I think the intent now is to turn to a discussion. I have on this summary, I have put a green highlight on those that I judged as having the most opportunity for cost containment and delivery system improvement. So, but you all may have a different thought process, but I was at least giving you the benefit of my thinking. And so the first one relates to engaging a third party to do per capita benchmarking, so that we can have data on good cost comparison data, and we can evaluate opportunities. And I've scored that one as green, as something that could lead to cost savings. The second is to have the Green Mountain Care Board summarize and synthesize their analysis and cost findings. The third one is to consider additional cost containment strategies for drug spending. The fourth is to look, and the third has got the green mark on it because of the amount of cost that's outside of the cost containment model and the growth in that. The fourth is about creating more alignment across the regulatory system. The fifth is for the consideration of an alternative fixed rate or global payment options for hospitals and their employed physicians. The sixth, and that is, I put scored that as a green. And the sixth is about developing expenditure targets. The seventh is about the data model and continuing to escalate the process about getting that data model and transformation workforce just right. And that is scored at green. And the last relates to the looking at the Green Mountain Care Board authority and the ACO structure to see if there are areas that need to be tightened in terms of for consumers or unaffiliated providers. So that's the 8 recommendations all brought together. And I think Chair Hooper, did we want to go through and have a discussion about those at this point?
Yes, so the thought that we have, I mean, so thank you very much for the presentation and for your clarity in laying out your findings and particularly the suggestions for how to proceed. The thought that we had was to look at the recommendations. I think, if they generally make sense to us, and I'm assuming from the conversation or the responses you're going through, I wasn't hearing people say, no, this isn't it, we need to think differently about X or Y. So I'm assuming that we're generally in the right ballpark, and the thought is to allocate out these recommendations to the different policy subject matter committees that would have jurisdiction and ask them to consider it. And I particularly appreciate that you've noted which are kind of the more doable or the ones that we should tackle now, just given where we are in the second half of the biennium. Those strike me as the ones that we should look at and, as I said, allocate out and see, if it makes sense to begin tackling them now. So I think I'm back to the committee members, and why don't we just start at the top with recommendation number 1, which is, I'm not going to read it, but it's asking the Green Mountain Care Board to engage in this per capita benchmarking analysis. Let me just, does this make sense, and who gets that in terms of kind of committee assignments? Senator Kitchell.
Well, it seems to me that that analysis is very helpful in forming next decisions. And we really believe, first of all, it would be to bring in additional resources rather than imposing an assignment on an existing entity. I guess probably to write the RFP would take some time. But if the Green Mountain Care Board, upon discussion, it's something that we could actually consider doing in budget adjustment with available funding to help us get, because, well, first of all, I commend you for interviewing 45 people and reading 30 reports. I think, we know that there's information out there, but we're really not getting the full benefit. And for legislators, we have no policy staff, we're, our own time is limited. So it just shows how much has been put out there, but we're probably not beginning to get the benefit of the data that we're collecting. So I would say number one is, it seems to me an important first step. And, I think from a money perspective, now would be the time to make the funding available. So I'd want to have discussion with Green Mountain Care Board, but obviously that's going to translate into an appropriation, and that would fall to Mary and me to make sure that that could happen if it makes sense with everybody else.
Senator
So, yeah, thanks. I think everything you said, Jane, really is on target, and the sooner we can move in this direction, the better off we are. But then we want to ensure that if we're looking at the language that's here in the recommendation, it talks about analysis of avoidable utilization and waste. And so what we want to ensure is that we're not going to be throwing babies out with bathwater. That utilization analysis really does look at quality improvement. And so if that extends into I will bring it up again, the quality metric analysis that's going on at the ACO. I see that as so important. Having VCURE's data is so important. Trying to get at private insurer data that we get it, thank heavens, but it would be great to have all the ERISA type data available. So there's a lot embedded in that one little recommendation for me that suggests that policy committees need to at least have a look at what the language will say. And then not the least of which is, as I'm seeing Representative Pugh on the screen, we know that we have external funding for our DAs, our SSAs, mental health, substance use disorder that links in with patient care and quality. And we don't want to categorically throw out those linkages as avoidable over utilization. So I think this is a super recommendation. I don't know, from where I'm sitting, I don't know that it is something that can be plopped into the budget adjustment really fast. And I hope that Jen Carby and Nolan Langwell are ready to go with this and help us, as well as our other committees. Oh.
My other comment to me, which is so important, better performers, because that really gets into the quality and health outcomes. Because we all know, would be concerned that we not do something that has an adverse impact, but are we spending money where we know that the outcome would not, the cost and the outcome are totally disconnected. So to me, the better performers would include quality care, good health outcomes, and at a cost level that is perhaps it would be lower than what we're experiencing here. So I do think, to me, that better performers is a really important part of that benchmarking.
It seems to me there's two parts to this recommendation, really, and I want to check back in with Donna, if you will, because you're talking about really engaging a third party to perform per capita benchmarking, and that then can be used for comparisons to national measures, peers, better performers, et cetera. And then this might also include an analysis of unavoidable utilization. I really think there's two different pieces here, and that the one might follow the other, but I'm aware that some states have taken efforts to look at avoidable utilization. But I think we need to be careful to not just merge the two and potentially confuse the process, because the one is not, because I think the per capita benchmarking is potentially used in a number of different ways, and separate from, and not necessarily just for avoidable utilization. I think the two are, I don't think we should conflate the two.
Sir, can you help us with that?
I think that what I could do is just to change the report and make it into two subset recommendations, because you are clearly correct that you don't have to do the waste and avoidable utilization analysis, but the benchmarking analysis will be extremely valuable even if you don't do the avoidable waste and utilization analysis. And in the report, I could also put some more definition around avoidable waste and utilization that might make folks a little more comfortable. The states that have done this have a lot of the waste analysis is based on national quality groups who have scored, and physicians around the country who have scored things in the Choosing Wisely these waste definitions that have been peer reviewed by quality experts and physicians. So I think I could add a little bit more detail for you in the report and modify the report to make that recommendation clearer and separate A and B, and to also put in the tie-in to quality organizations.
Can I just be clear? I don't want to have anyone misunderstand. I'm actually very interested in the avoidable utilization piece, but I think to have them linked as if it's one is an essential piece to do the other. I think I like your suggestion of maybe dividing them out into two separate pieces. And then again, we can think about what's timing and what's the priority. I personally think the benchmarking is the highest priority here. And we have to think about what can be taken on by whomever we're asking to take it on.
In terms of the process piece that you raised, Senator Lyons, given that we're beginning, the House begins the BAA, we will consult with the subject matter committees. They'll help us with formulating what the suggestion is. So I think there's time to dig into this. You know, if we identify it now, we can get this to people rapidly. And by the time it gets to you, to the Senate, you know, there's a month plus of
It'll
time.
be by the time it gets to us, it'll be perfection.
Yep, there we go.
So the question, and what is the timeline for the BAA? Look at Mary and Jane for that.
My plan is to vote it out of the House Appropriations Committee on the 14th of January. That may be overly aggressive, but just given the way we, you know, the normal flow of things, that's what needs to happen.
Well, so thank you. And so I think it will be important then for our committee to at least go through what the recommendations are from Donna's group, and then we'll have, at least my committee members will have an understanding of where we are. And so we can move forward together. That'd be great.
Terrific. Rep Q?
Um, I guess I will need some clarification as to sort of which data set we are dealing with, because very parochially, the issues that fall within the jurisdiction of human services, one very clearly crosses with healthcare on the House side, which is things related to community mental health and substance use. But then the other piece in terms of some of the long-term care kinds of things, which are not in one of the data sets. And so I will need some clarity as we move forward as to whether those things are being looked at and dealt with and examined, or whether that we're leaving that for another day.
And my thinking was that we would be focused on the VCures data that could be drilled down to a more refined level in terms of the benchmarking. And that would be the primary source of benchmarking data. There may need to be some consideration of how the mental health expenditures are funded in that process, but I wasn't focused in that recommendation on taking on benchmarking of long-term services and supports, for example. But that you could have a different thought process, but that was the one that I had, Representative Pugh.
Okay, so generally have a plan for recommendation number one. I think we should focus, unless people disagree, on the ones, just given what the time is, on the ones that have been suggested as green, as the ones that we should turn to more quickly. I will say for number two, my thought has been to just ask the Green Mountain Care Board to do executive summaries of their reports. And I'm planning on just that being a conversation when we see them during the budget time, and just conveying that to them. If we can see if that happens and move on. So turning to number three, the consideration of additional cost containment strategies for drug spending. This strikes me as falling squarely on the shoulders of the Healthcare Committee on our side, and Health and Welfare on the Senate side. And so Bill, Rep. Lippert and Senator Lyons, we look to you for your thoughts.
Can I ask a question of the two chairs of the cost containment, or the whatever your group called you?
Healthcare task force.
Healthcare task force.
Affordability, accessibility,
It
something
seems
along
like
that line.
the cost of drugs must have been something that you have been bringing up and getting testimony on as part of that. So is there an intersection of that recommendation with really the work of the task force? I was just wondering.
Well, I think there is an overlap here. One of the, we haven't finalized recommendations, but we'll be meeting next week, and then again right at the beginning of the session. One of the recommendations looks at possible additional regulation around PBMs in particular, and but it does not say that does not go into some of the. I know that we're familiar because we've looked at these issues over and over in our committees. This is not new area, but some of Nashby's recommendations have talked about creating drug affordability boards. I think in Vermont, that would be something that would be potentially located within the Green Mountain Care Board. And I would say that is a major, something along those lines would be a major initiative, and not something that would be undertaken in any short-term way, or whether it's even advisable what it would be taken. So
yeah, I'll agree with Bill. We are taking this up in the task force. We will have recommendations, and one of which will be PBM. I will also say that there will be prescription drug bills legislation introduced, at least I'm sure they'll be on both sides of the legislature, but I know that we'll have some in our committee, and some of which are being proposed by Department of Health or others that will move forward with some support from the administration. So there will be a lot going on. And we'll just, if there's some creative ideas that come up while some of these bills are in process, we can put them all together.
I would
And
say
I know that, I think Finance Committee may want to weigh in on some of this as well at some point.
I would also say that I think one of the more at least as I'm looking at this, something that we have not generally looked at is the relationship of the ACO to drug issues, prescription drug issues. And I think that this highlights that potential. I have some broader comments I want to make about I think there's some implicit recommendations within these 8 recommendations, which we should talk about as well, which is affirming the role of the Green Mountain Care Board as an important part of our regulatory healthcare structure, and the issue which has been talked about later in the report, which is around differing points of view on the all-payer model, accountable care organization. If we're talking about building on these structures, for me, it begins to, I think we need to be clear, are we moving forward in these models or are we not? And I think that that's one of the things that I'm taking out of these recommendations, is that there's implicit affirmation for some of this. And I think we get tied up in the cross waters of points of view on all this. And I think at some point we need to say we're moving forward, and we're not going to spend too much more time on reevaluating whether we're in the right model or not. And I think that's part of what, at least as I look at this, that's part of what I'm taking from this. But I think that that's one of the challenges that we have in trying to move forward. So that's the broader comment. That's would be very interested with others' points of view on that. But I think around prescription drug issues, whether and how to implement that or integrate that with the ACO model is an area we have not looked at.
Donna, I have a question. If we're moving more and we're getting increased enrollment in the ACO, which is going to be risk bearing, to what extent, it seems to me that in fact, with that risk dimension at work, that internal to the One Care, there would be a great emphasis on guiding on that physician response to what they're doing with prescribing, because of the cost implications. Right now, it's not there because pharmacy costs are outside the all-payer model or the ACO. So if we're at some point, are you recommending that in fact pharmacy we should bring that in to the ACO risk bearing?
Let me be clear. I am not recommending that the providers should take risk for pharmacy, but there might be an appropriate shared savings model around pharmacy. The pharmacy risk is too big, and it would be too much cost responsibility to put on the ACO. And quite frankly, it brought down a lot of entities in the 90s when they tried to take on pharmacy risk. It brought them down. And because they were taking responsibility for a cash item that wasn't part of their own budget. And so mostly the ACO is tackling things that are part of its own budget that it has some control over. This pharmacy thing should be part of a savings model if it's put through the ACO, not a risk model. So that's my recommendation. Others may have a different opinion, but my opinion is it's too big to put on that risk on the provider organizations, but shared savings responsibility could be considered.
Okay, that's very helpful to
Yeah,
clarify.
thank you. I couldn't agree more. It's terrific. Thank you.
So in terms of the thought process around this particular recommendation, it sounds like there is a lot going on within the two bodies, but at the end of the day, they both land in the healthcare committees. And I think what we're clearly saying is big target, no news that this is something that needs to be addressed, and whatever steps could be taken that move us are wise.
Right, and I think, again, I think it's fair to say that this has been an area of some active work in both our bodies, and some of it not to, with the outcomes have not been as successful as we'd hoped, some of the initiatives, but we've been trying to stay on the cutting edge of trying to see what we can do here. I also think we have to take into account, we have to integrate whatever we're thinking about with other initiatives that are happening through some of the providers. The insurers, which are also taking initiatives around prescription drug costs because the costs are exorbitant. And we all know that it's one of the big drivers right now of our healthcare costs.
So, thank you. Bill's Rep. Lippert has also suggested another large topic, which is the role of the Green Mountain Care Board and the ACO. And I mean, this has been kind of a sub-theme that has been going on within this discussion and certainly within Vermont, at least within my email system, for a number of months. And I think it makes sense for us to have a conversation about that. My suggestion is that let's move through the recommendations, finish that, and then at the end of it, and then let's have that conversation about what we're learning and what we think this committee should recommend, or what our thought processes are with regard to that issue going forward. Okay, so that was number 3, and so moving to 4, which is again one that's not green. Big task, lots of conversation. I think it also belongs to the healthcare committees, unless it also belongs to the finance committees, I'm not sure. But I'm willing to just let 4 go and turn to 5. Yeah, okay. So what are the thoughts around that? Consideration of alternative review fixed global payment options within the ACO APM model framework.
So Mary, I think, we started talking about this when we had the folks in from Johns Hopkins, and then again, when we heard from folks from Maryland and others, and now Donna. I think a global payment discussion is absolutely critical, important. We know where a lot of the resources lie. We know that those are in hospitals. We also know that even before COVID, our hospitals were in the red, many of them. And if we're going to sustain the hospitals that we have and that we need, this becomes a really important discussion. So moving away from fee for service globally is probably a good thing to consider. And then as we talk about the role of the Green Mountain Care Board, that and the ACO, this will fit right into that discussion as well. I don't have any other specific ideas at this point. I mean, I have specific ideas, but I just think this is something to keep on the front burner.
And again, that belongs in your committees. Yeah, okay.
Thanks.
And I think, is it fair to say with an understanding, I think these are this is an area where a timing issue is, I think, I mean, this is not something which frankly, I could see us trying
It's
to.
not going to happen this session. It's
Yeah,
going to-
exactly. I mean, this is not something, to move to global payments is not something that's going to just, you do on a dime. I think this is going to involve some real thinking and planning.
But
And
aren't-
consideration.
I do have a question for Donna, actually, and that is that, you know, as we consider our ACO and its relationship with our hospitals and our providers, we're very much focused on primary care. And so if you start talking only about primary care, it leaves out all the inpatient specialty care that goes on and the effect that that has. And I don't know what thinking has gone on while you've developed your recommendations. Any comments that you would want to make about that?
But I think the bringing the I think you need both. You need the primary care focus because getting the prevention and the chronic care, really knocking that down is really critically important to not only the health, but the savings on a long-term basis. But bringing the other participants into the system and doing that more fully by getting more of the participants engaged when they're not tied to fee-for-service is kind of the other part of the equation. Your blueprint model is, among the best, if not the best in the country in terms of a primary care model. It's among the best. And Maryland started in the other direction. They started with their hospital model, and then they built the primary care model, and they're still trying to get the primary care model up and it's running for about half of the Medicare population, about 400,000 people, but they're still working on getting their primary care up and running. So you're definitely ahead on that front. But the hospital piece, the hospital and the specialist are getting more aligned through the payment model. And so that other payment model with the hospital and the specialist and that global payment model helps to bring the whole system more into alignment around the goals. So I think that's really there. In terms of timing, I do want to say if you go down this road, it will take some time to implement, but if you will need to start considering it because it would change your next generation proposal to CMS if you were going to incorporate this a global payment, because you will want to fix the payments that CMS makes for the hospitals. And let me just give you an example of an advantage of that. About a quarter of the cost in the hospitals are from out-of-state patients. So that if you put them on the fixed system, then that money gets pulled into the equation also, so that they have aligned incentives for the patients from in the state and out of the state that may not come under the ACO now. So it brings more alignment across the entire set of patients that the hospital's working with that might not get picked up in the ACO model because they're going in and out of state. So these are non-Vermont residents, but you want your doctors to do the same thing for the same good things for every patient. And you want the hospitals to do the same good things for every patient. So this helps to align what they're doing across all patients. So that's part of the consideration. But so you would need to get started, even though you might not implement, to consider it, whether you want to do it, so it could be included in a program with CMS. And it wouldn't just be a Green Mountain Care Board activity, it would be across your agencies, because it affects Medicaid, it affects the Office of Healthcare Reform. So it needs executive branch and Medicaid participation in any consideration, not a single agency. I hope that's helpful.
Yeah, I find that helpful.
Yeah,
Yeah, I
thank
find that
you.
helpful. Thank you.
And I'm wondering if you could give us some additional ideas in terms of what the shorter term steps are that we can be taking to move us in that direction. So that might just help the committees in their thought process about, okay, we have the ability to do this year, to push it.
Well, and interestingly enough, if I may, I've been sitting here thinking, can I text somebody or get the message like, is Ms. Kinzer, is Donna available to committees to do any follow-up thinking and analysis? Because I think what you're suggesting, Mary, is excellent, and if that could be incorporated into the help us think more specifically, but also it may be useful for us to consider whether any kind of follow-up consultation would be
Would help.
to have some
to support the
continuity of
committee, yeah.
to have some continuity of thinking and analysis as our committees might take some of those next steps.
Noel, Mr. Langwell, can you help us with that?
Yeah, I was just going to say that our contract doesn't, we'd have to do a contract extension because a contract we have is for the work that she is doing. So for availability during the session would have to be some kind of contract extension, and we'd have to talk with Donna to see if she was interested as well.
Right. Well,
Yeah.
I'm just putting it out there,
Yeah.
not trying to come to a decision
Yeah.
while we're here, but
Yeah.
just to say that might be something that would be useful.
I think your comment really ties into the fact that committees need some help and support, and this is just sort of how do you frame that first step and think about how you stage it, and it's Donna saying get started. Well, what does get started mean in real terms? So,
But if we're going to make that investment, we need to be clear that we're intentional and we are going down this path.
Well, let me also be clear that we have whole committees
Yeah.
which make decisions, and our committees are not going to be up to speed the way we are sitting in this room with the conversation analysis. So there's going to be groundwork. And
But
conversation.
that's such a good point that you make, in particular with regard to how the ACO and APM are valued within our individual committees. So it's a heavy lift for some of this.
Okay. So we have some thoughts on how to handle number 5. Again, I'm just going to ask us to focus on the green ones. So unless somebody wants to comment on number 6 about the developing health expenditure growth targets, we're going to move to number 7, which is continue and escalate process to consider data models and strategies to drive delivery care transformation and cost containment. Ellie, who does that belong to? Rep. Lifford and Lyons, Senator Lyons. And what are your thoughts on that? And
Yes. I think we heard loud and clear how important having a data model is for providers and for others. So yes, I think this is something to pursue. The question is, how much can we do legislatively, and or is it a direction that we can give to the Green Mountain Care Board and others to accomplish? And Donna, I'll look to you for your thoughts on that.
No, I think the Office of Healthcare Reform needs to be involved in that recommendation.
Office of Healthcare Reform.
Can you
Office
come?
of-
Healthcare
We're not hearing you.
Oh,
Yeah,
Very-
we lost you again.
Can you hear me now?
You're a little light. I don't know what's happening.
Suddenly dropped off.
Yeah.
So, are you hearing me now?
Yes, that's much
Okay, I
better.
just moved up closer to the computer, so
Okay.
I'm usually leaning in, so there we go. So I think the Office of Healthcare Reform should be involved in any discussion about data model strategies, as well as the folks in Medicaid, who have funded some of the data model approach, and stakeholders. But if you are going to go beyond, as you start into the transformation, if you are going to go beyond just the ACO and create fixed budgets beyond the ACO, you'll want to have that transformation data flowing for all individuals and all residents of the state to help with the transformation. So it may cause you to want to use some other vehicle partially, like the Health Information Exchange or some other vehicle, but it really needs more thoughtful, deep consideration to come to a conclusion with some stakeholders at the table, but with the Office of Healthcare Reform, as well as a collaboration across the agencies.
Yeah, it's part of. Yeah. Okay. Rep. Looker.
Well, I'm just going to take this as an opportunity to say, and I've said this before, I think, I don't know if I said it here, I think I may have. This, when a number of these issues come to the healthcare committees, we do not have, in my mind, sufficient staffing support in terms of healthcare analysis. And I want to be very clear. I've said this, I've been very clear. This is not a reflection on Nolan or Jen, but the range of things that our committees are asked to take on and think about require, in my mind, some additional ongoing staffing. So it's not just an ad hoc consultant available here or an ad hoc consultant available for another piece, but something to help to provide ongoing analysis and legislative support to the healthcare efforts of the legislature. It's a genuine concern. I feel it regularly, and I think at some point, not today, perhaps, but at some point, I just feel like I need to register that concern. That I think in the past we've had, prior to my time, I understand there was additional staffing directed to healthcare, and I think it's something we should look at again.
So you raise a really good point.
To expect all this to be happening when we're not adequately staffed makes it a challenge, because we are not. Part of why we're asking for this analysis is because we, as citizen legislators, are not in the position to do some of the analysis that we're asked
I
for.
would just say, I think I brought that concern up in front of the Joint Fiscal Committee earlier this summer.
Well, we have to revisit what we did in the past, which didn't, we ended up not, we had that office to support the legislature. It was headed up by Jim Hester.
Well, and again, as I said, it's before my time, so I'm less familiar with it, and I know there were other big ideas on the horizon that may have been part of why that, but there
maybe we
are
need to
needs we
revisit
have
that.
now that are just not able to be met by the highly competent staff we have, but it's not sufficient.
So
Senator Lyon?
are we, I want to be very careful that we don't try to go backwards. We're going forward and we want to make sure that, I know right now we have a Green Mountain Care Board. We're asking them, should we follow the recommendation that we have before us? We're going to ask them to do some summary and data analysis summary and get us the information that we need. I put this together into that area. The problem is that the Green Mountain Care Board is not an arm of the legislature, nor is the Healthcare Reform Office in AHS an arm of the legislature. But having some coordinated work being done that informs us is critically important. Do we need a separate office? I don't know. We certainly, I would love to have 3 Jen Carbys and 4 Nolan Langwheels, more, so, but we don't have that. So I don't want to just say, let's go back to the Healthcare Reform Office that we used to have, but let's think about a way to maximize what we have currently and how to build some nexus. And the other piece of it is that we haven't really talked about is part of our reform is to integrate as much as possible community mental health, substance use disorder, long-term care issues that I know are sometimes left outside. But we want to make a fully consistent, integrated system of care for folks. And so that's a whole different kettle of fish.
Sure is. And please do not interpret anything I said as we should go back and reconstitute. I'm just saying at that point, there was a recognition around the heavy lift and the resources and expertise to support the legislative process that we didn't have in this big area. So I think this is a discussion we probably have to have. I'd say probably many other committees would articulate the same desire. So it's a concern inherent in being a citizen legislature with absolutely no policy staff.
That's right. I mean,
And which makes us very dependent on those other entities outside the legislative branch. But that's a longer discussion.
That's a much longer conversation. So we've worked our way.
Having these things referred to our committees, it just requires me to voice my concern of having expectations laid onto a policy committee that doesn't feel like it has the resource.
As I said, I think I brought that up in context as we talked about joint fiscal earlier in the summer. And I would, to back up what Senator Kitchell said, I think large infrastructure bills coming through, that you would hear the same thing from the Natural Resources Committee that are going to have to deal with sewage treatment plants and all of the things that are around there, that there will be issues there. So, and I think the policy committees feel somewhat left out.
Well, there's just a whole host of areas, and that's one thing is spending money strategically. The other is a whole transformation of our systems and these disparate pieces that are trying to be designed in. And so at least in the short term, I think Representative Lippert has said it would be very helpful if we could continue Donna's support, involvement, and expertise to help at least as in the short term as we're continuing on the recommendations that are included here and the support committees would need. So I think that's something that we at
Perhaps
least
that's achievable.
that to me that in the short term would be a good step and achievable to help the policy and subject matter committees with taking these recommendations and making sure that we get the greatest return for the work that you've done for us, Donna, because it's really I'm sure you spent hours to get us this report. So you'll be hearing from us.
Well, thank you. And I do echo that what Senator Lyons said too, that we need to really ask the Green Mountain Care Board to do more for the legislature in terms of synthesizing and summarizing and interpreting all of the reports and consulting studies that they've had done and making that more useful to the legislature. You all aren't going to sit and read 30 reports or 40 reports. And, I'm an expert at reading those reports, and some of them are complicated. And so I think they need I do think that Senator Lyons, that the board can do more for the legislature and helping the legislature, even though you may need some other resources. So thank you.
Okay, so it's 11:30, and I know we've gone without having a break here. But I would just like to come back for a moment to this conversation about the role of the Green Mountain Care Board and the ACO, and Rep. Lippert said earlier, implicit in this report was support for the structure that we have, with some significant recommendations for change in the evolution of that report. But I'm wondering, maybe, and I'm perhaps putting you on the spot, Ms. Kinzer, if you can reflect on some of those conversations, because I gather they came up explicitly in your interviews, and just help us understand what you were hearing and why you implied, at least, that that we continue on this path. Yeah.
Or perhaps ask. I'm drawing that conclusion.
Yeah.
Maybe it'd be fair to ask if that is an accurate conclusion to draw from the nature of your recommendations.
Yeah, so I would say
Will
yes.
you lean in, please? We're hearing.
Yeah, that's better. Thank you. Oh, dear.
No,
Now you're
You
totally
muted
gone.
yourself now.
You're muted.
you're muted.
That you couldn't hear me because I was muted. There we go. Sorry about that. I agree with your implicit reading that, and really I tried to be fairly explicit that there's general support for an accountable care structure. And I'm also trying to point out that this is the national strategy with CMS. If you look back at that page 33 of the document, and if you read that national strategy, the national strategy is all about trying to have more accountability by the providers for cost and outcomes. And if you read that strategy document, the federal strategy is also about building a strong primary care model component, as you have, into that process. And it's about focusing on ways to bring providers off of fee-for-service into a value-based arrangement, maybe not 100% off of fee-for-service, but more into the value-based arena. So, I think what I heard from some of your folks was they didn't necessarily disagree with the strategy, but they had some problems with the implementation. So if you have some problems, maybe the focus needs to be on fixing the problems rather than getting rid of the strategy, which is actually a good strategy, I think. The issue then needs to focus on how do we make it work better. and as opposed to we need a brand new strategy starting from ground zero. So this focus is on, the report focuses on how to make the strategy work better. As I'm not sure if you threw that one out, where you would land. So a primary care strategy by itself isn't going to get the job done. I think you all pointed out that you need more than just primary care to contain costs. So this is the accountable care strategy is more comprehensive. So it builds on primary care, but I would be concerned that you don't have a strategy at all if you move away from accountable care strategy.
Senator Lyons, thank you.
No, thank you. That really is a very well put. I think it sort of explains a lot of what we hear. On the other hand, what some of us hear is, oh, we just don't like the ACO, but we do like the all-payer model, and then the comment that we could have all-payer without the ACO, and yet some of the values that are embedded in the ACO are critical to improving access and reducing costs. So I guess that's just a comment, but it's difficult when you've got a significant number of not a significant number. It's rather a small number of very vocal people, naysayers against the ACO and not allowing for progress going forward. So how do we make the change? What do we do? I think those are the key questions that we need to continue to ask ourselves. And how do we integrate specialty care? How do we go toward community service coordination? I mean, all of those things are important. And our ACO is a hospital ACO. I guess that's the model across the country. If there were a way to have a better integration of our community services within the ACO, that would be a super. Just some comments and thoughts, but we do need to reinforce that we have an ACO, and we're going to try to continue working with the federal government with this model.
And then also the understanding and the recognition that there is room for improvement. And we have a proposal, a series of recommendations for the steps that we could take to improve it. So we're not sitting with where we are. We're continuing to work hard to improve the system. Senator Kitchell.
Well, the other thing I think we need to do is have a better understanding of what this new payment structure means. And earlier this summer, I had there was a Facebook exchange with someone who was concerned that our mental health agencies under the new payment reform were getting these payments, even though the volume of services was not the same because of COVID. And yet we knew that those payments actually helped stabilize and kept the revenue stream going to those designated agencies. So one of the complaints is, well, they're getting paid to do something and they're not doing it. And yet that's very much within the context of the fee-for-service model. And so I do think that, we're in this transition period. There perhaps is an area for more understanding about how that payment model works and functions.
I've raised this issue with the Green Mountain Care Board on multiple occasions, that I think the communications around this model are simply insufficient in terms of helping. The language itself is confusing, the language we use in terms of all payer versus other language that's similar, et cetera. And but I think there's a lot more that could be done to help members, frankly, even within our body, but also the broader public more specifically understand what it is that this this transformation is attempting to do, how it's something that requires time. And there's room for improvement, but I think I'm at the point where I feel like we need to somehow make clear that we're moving forward with the model and to not be spending a lot of extra energy redebating whether the model is the model that we're moving forward with at this point in time. And I think similarly with some of our regulatory structure around the Green Mountain Care Board, I think that we need to, if we're going to build on it and try to improve on it and strengthen it, then let's do that. And rather than to be constantly questioning whether we have the right structure. So I'm just going to put it out there.
Senator Cummings and then Rep. Hansel.
Well, listening to this, I've been at this a long time. I remember when we sent out counter detailing teams to help doctors understand that it cost half as much to take 3 pills a day as to take the new and improved 1 pill a day with a time release formula. And I think that was John Matthews from the Plainfield Clinic that gave us some really insightful things into pharmaceuticals. But for the committees that deal with it every day, it's, you know what you're talking about. For the average person in this body, never mind in the public, they don't know what, I mean, we decided on this model and this course 10 years ago, and I'm just thinking of the briefing we just did on finances, which is a lot clearer, and numbers tend to add up, or should, where this doesn't always, and it might be really good to do a briefing similar to what we did on pensions last year, which I think was very helpful, just pensions 101. So we all started with the same base understanding. And I think it might be good at some point to do maybe a couple of the lunchtime sessions to help all of us at least be, when we say ACO, we know we have the same definition of what an ACO is.
Thank you. That's it.
Because I'm still trying to figure out how the blueprint fits in all of this.
Well, it's complex. And
Yeah,
I don't pretend to.
Rep. Hansel.
So, yes, complex, a lot of money that affects everybody. I mean, when you think about what it is that we're talking about here, it's huge. And I guess just reacting to the comment that you made, and I'm not sure I understood it. So if I misunderstood it, tell me, that we should sort of affirm our support for the current regulatory model and move on. I'm not saying that we should say that we don't support it, but I think we would be irresponsible not to continue to question it all the time. And I think it's our job to say, is this working? Is this structure the regulatory model that we need right now? And I would continue to ask that question next year and 5 years from now and 10 years from now. So I feel that the question, I'm going to this number 8, which we haven't highlighted in green, but this question about whether we should evaluate whether the Green Mountain Care Authority and the ACO provide sufficient protection. I think that is a critical question.
I think those kinds of, I would absolutely agree with you.
Yeah, I assume that you probably do, but I just want to be really clear that being skeptical and being questioning doesn't mean that we're getting off this path and that we know another path to follow. It just means we're doing our jobs.
Senator Westman.
As a follow-up to that, what I've never been really clear about is what the role of the ACO and where it bumps up against the Green Mountain Care Board and who does what. And I think that we've never been really clear about what that is. So I totally agree with you that we need to question that because we've never really thought that through.
So
Rep-
let-
Hang on, Rep. Lippert.
Well, I just want to say that I am completely in support of raising questions and looking at how to answer questions and make improvements. What I'm after having chaired this committee now for a number of years, it is not helpful to us, in my view, for us to relitigate whether we should have a Green Mountain Care Board and as the core component of our healthcare regulatory structure and to have proposals made. Well, let's go back to Bishka. Let's do what we did before. Let's do that. I mean, I think there are two different levels of skepticism and questioning. And so I share some of your concern that we should constantly be asking questions, but I do think there's a point at which we need to say, and I think this committee frankly should have to engage this, because this is, if there's a committee that's talking about healthcare reform, this is it. That we in fact are supporting the current regulatory structure that we have at this point with the ability to continue to ask questions and find improvements. But that's a different frame in my view than I don't know, I kind of think that somehow the term relitigate comes to my mind as useful. Maybe that's not.
You're looking at a lawyer.
Well, no, but I'm not. But I think it's coming out of my work from judiciary as well. To be honest, Jen, I don't think it's just directed at you as a lawyer. But it feels like there's different levels of skepticism and questioning, and I think it actually makes it harder to move forward. It feeds other lines of questioning, and sometimes even, and I'm not suggesting that there's also misinformation that's put forward that then gets ahead of steam. And so I felt like I needed to say this because as I looked at this report, I mean, that was, to be honest, Donna, one of the things that jumped out at me was, I think this report, it starts with how to strengthen, how to modify work of the Green Mountain Care Board, how to modify the ACO model. And I thought, I need to say that I think what I took as implicit perhaps needs to be made explicit. So.
Senator Lyons.
Thank you. And it has been an interesting process in our committee as the ACO was put into statute with specific principles. And then our committee took a trip to visit with the ACO, and I think Senator Westman, Senator Cummings were on committee at that point when we went to have a more in-depth discussion with those folks. And then we also looked at and had an in-depth set of testimony from our Medicaid folks, our health reform folks, and others, so that we could fully understand ourselves, what's happening. But I do agree with Senator Cummings that this is difficult to understand when you're out on the street and somebody says, "Oh, tell me about the ACO. How's that going?" That's not something that is easily explained. So I do think it would be helpful to have some series of presentations within our caucuses in the State House to educate people, period. I just think that's so very important. Members of my committee need it as much as any others, as many times as Nolan or Jen have come in, as Green Mountain Care Board, as administration has come in. It's been difficult. having said all that, it's really tough to get away from the political environment. And so we have an administration that I would like to have at my side, working closely and understand exactly what they're doing. And it's pretty good, but there's a lot of work to go on that goes on, and all of us are understaffed. The Green Mountain Care Board is the other part of it, and they've been very good about helping us, but now we need to redefine what help means. And so asking the questions not about, is the ACO the thing we want to go forward with, but rather, how can we improve the process? How can we make it more transparent in terms of understanding? How can we build the quality outcomes, the clinical outcomes that are so critically important for preventing long-term illnesses and hospitalization? And then at the same time that we're preventing all of that, how can we maintain our hospital infrastructure? This is not an easy place to be. But it's kind of a neat and it's a good place to be. I'm very happy to be working in this really complex environment, and I just think we can keep going forward. But I agree that we need to affirm that the ACO is there. There may be other ACOs, we don't know. We need to affirm that primary care and prevention is the first step, and that the next step is to try to have some more global budgeting across the board so that we have sustainability and sustain the clinical care and the hospital care that we need in the state for our 600 or so thousand citizens. Oh, that's all. It's a
Senator
big,
West. Yeah, thank you, Senator Lyons. Senator Westman.
For me, one of the important things is in the first recommendation where they talk about hiring a third party to collect the information. I think we've had a really hard time, particularly with the Green Mountain Care Board, separating their regulatory job with how they collect all the information that's out there. And we've got them running in so many different directions that they're not able to focus on what they need to do. And I think that in all of our discussions around that, we should remember that too. And I go back, I think I see the Green Mountain Care Board myself as the regulatory piece in this. And how does that fit with the ACO and the regulation that they're going to lay out? Who's got the guidepost and who's doing it?
Can I suggest, I think this is a discussion that we would benefit from having, again, and in more depth, because I think this is sort of, for me, this is in many ways at the heart of what we need to really wrestle with together and think about together. And I think
You're asking for another meeting?
no, I don't know. I hesitate
A little
to do
tiny break before.
A little tiny break.
Well,
would be good.
so our
Yeah, but I
dilemma
guess
is-
I'm just saying, I think this is a very important discussion, and I think
Yeah.
a fruitful one, frankly.
And I think part of what Richie said goes back to what Bill said. I've often felt that we use the Green Mountain Care Board as our research arm because
Don't have any of it.
and so if we want to know something, we tell the Green Mountain Care Board to study it and report back. But all the time they study it is time that's not going into the other things we want them to do.
And the other part of what makes all this so complicated is that when you want to implement something, there are various places that you can go. There's Medicaid, there's the Health Reform Office, I think is its name. There's us, there's the Green Mountain Care Board, there's the ACO, there's, so it's hard to know exactly. And so a lot of my questions come out of the fact that I agree with Senator Westman that we need to further explore the relationship between the ACO and the Green Mountain Care Board. But I also think we need to look at the whole plate, and say, is this structure working the way we want it to. And nobody built it wanting it not to work, but we built it wanting it to work, and we just need to keep asking the question, is it working?
We've got 18 weeks.
Yeah.
Can I,
Unfortunately, we have years.
Madam Chair, may I interject a comment, please? Because I don't want to, I don't want to leave thinking that we haven't thought about the role of the Green Mountain Care Board and its regulatory role versus its sort of investigative role. And one of the concerns that our committee consistently has around alignment between and among. So we have private insurers, we have Medicaid, we have Medicare, we have different sets of rules, we have different needs. And I have not gotten to the point. I do think that there's an issue around how the Green Mountain Care Board follows through with its investigative work versus its regulatory work. But I haven't gotten to the place where I see pulling those things apart. And so I think we need to be very careful about making holistic, large decisions and transitions, and rather look to see, can we make improvement going forward? And so I know that Senator Westman and I, in our committee, we've had long discussions about the role of the board in regulation versus I call it investigation. But the value that an independent board brings in both of those areas is significant. So I like to think about how can we align our system in a better way so that we understand the regulation that the board is doing. There's a lot here.
Thank you. So I'm very aware of time. I know other people have made commitments at noon. I'm going to give Senator Kitchell the last word, and then we'll figure out how we're going to continue, or you're going to help us figure out how to continue the conversation.
Well, I think I would agree that this needs a lot more discussion. The Green Mountain Care Board was created in a different time, in a different environment. It was back with a single payer. Obviously, the progression now with the ACO and the all-payer model, I think we're asking legitimate questions. Do we, just like the system needs to transform, does the regulatory system need to adapt? And do we, and the way, because no one's debating that there should not be a regulatory structure. But I think Donna's report and recommendations are certainly identifying areas where we need to have a discussion around how we align a regulatory structure that was created and changes and modifications that are necessary as we move into this new environment. The ACO, if we get into, and we have one ACO, we're actually creating potentially a monopoly. And the regulatory requirements and moxie that comes with a monopoly cannot be underestimated. So I think that this has been really fruitful because it's put out the fact that we are going to have to really take a hard look at what got created a number of years ago, where we are now, and where we need to recalibrate or whatever to meet the demands of today and the path that we're setting ourselves down in the future. So with that, I think we absolutely are going to have follow-up discussion because we're going to need to call it a day and let poor Donna get back to.
And I apologize. I thought our agenda went till noon.
I did, well, that's what was on
I
the.
thought our agenda was 9 till noon, so I apologize.
Yeah,
That's what was on the Zoom.
And we're right on time, but we don't have time to.
No,
I know people wanted to have a break and maybe continue the conversation, but that's not going to be possible.
No.
So, thank you very much, Ms. Kinsler. This has been extremely helpful and interesting work that we're clearly going to all continue having conversations on. So to the committee, also, thank you all for spending your time in this way, and let's figure out how to have this ongoing conversation so that we can do this good work. So with that, I will